If we could have everyone get to their seats, we're just about ready to begin. Our next speaker is Dr. Alexander Borsand. Alexander Lightstone Borsand realized after finishing his allopathic education at Aureus University School of Medicine that he did not want to keep the standard of sick care he had been taught. He attended Southwest College of Naturopathic Medicine to increase his knowledge of natural alternatives to prescription medication. He then became a diplomat of the American College of Lifestyle Medicine, where he studied the lifestyle interventions that prevent and cure metabolic disease. Dr. Borsand was first introduced to hyperbaric medicine through a personal injury that would forever change the path of his career. After suffering a crash injury, 5 surgeries, and a non-healing fracture, he completed 60 hyperbaric dives with dramatic results. The non-healing fracture had started to heal, and the pain was non-existent. Through this personal experience, he decided to become more involved in the hyperbaric community, getting his functional medicine certification in hyperbaric medicine. Ladies and gentlemen, Dr. Alexander Borsand.
All right, thank you so much, everybody. I think it's about time I update that. That was 2 surgeries ago. And so I think just like many other people here, it's always a personal injury or a family member that gets us involved in hyperbaric medicine. And unfortunately for the rest of the medical community, they don't have that experience. They rely on us. And unfortunately, they don't believe us. So we have to use our research and what we've learned and really dig down, and with our new journal, reach out to these people and let them know that there is real research at all pressures. So we're gonna be talking about rheumatoid arthritis again, but we're mostly gonna be talking about the different mechanisms and how you can use these mechanisms to better understand how you might be able to treat something that you might not have a lot of research on. So a tiny bit about myself, he said all of it already. I do own hyperbaric clinics in Arizona. I do teach for one of the boards here, so I am always available if anybody wants to reach out to talk about hyperbarics. Some disclosures, I own multiple clinics. I'm involved in hyperbaric chambers and that aspect. So the learning objective here, it's really the rationale for treatment. You know, just like Joe always goes over, we have to have our standard of care that we understand, the mechanisms of HBOT, the risks and benefits of HBOT for this specific patient population, and some of those synergistic effects that we can talk about here to understand how the standard of care still applies for some of these patients and how hyperbaric can really maybe replace that standard of care for some of the other patients. So there is a publication that we have submitted here. It was submitted, it's still in peer review, to the Journal of Clinical Rheumatology. Very excited to hear back from them on this. If we don't, we'll be talking about it here for IHA. So, rheumatoid arthritis. I am not gonna get deep into rheumatoid arthritis because the reality is that I expect you understand it pretty well at this point in the day. I do want you to understand that it's extremely prevalent. And a lot of your patients coming in might not recognize that's what they have. And it's up to you to look at your patient and say, do you know what? This isn't just a little bit of swelling. This isn't, you know, typical arthritis. So you have to understand that rheumatoid arthritis is significantly different than osteoarthritis, and they present in different patterns. There's different age ranges that we talk about. Now, we saw this earlier. We have an absolute epidemic of autoimmune disease in the United States and really worldwide. Talked about the doubling the prevalence of that ANA positivity. And it's interesting because that anti-nuclear antibody, it doesn't really always mean autoimmune disease. You can get this with post-Cipro syndrome. You can get it from carbon monoxide poisoning. And I promise we're not going to talk about carbon monoxide too much. However, UHMS's newest journal this last quarter, another publication on carbon monoxide. Tom wasn't joking when he said that every time they publish, you're like, really, again? I love that we're learning more about it, but let's look at what's out there that we can really make more changes on that we need to understand. So there's a major economic impact to autoimmune disease and rheumatoid arthritis. In the United States, we're talking about $19.3 billion spent on this. It's estimated that RA costs a minimum of $10,300 a year for a patient, adjusted for inflation for $2,000 there. Annual medication costs can reach $22,000 to $29,000. It's outrageous, the costs. So if we talk about the pathophys of rheumatoid arthritis, important to understand, of course, we understand this attacks the joints, most specifically the synovial tissues. Why is it important to understand exactly what tissues we're talking about? Well, in hyperbaric medicine, we recognize at different partial pressures of oxygen, we get into different tissues. We know that we need 30 to 40 millimeters of mercury to create new fibroblasts, and we know that we need higher levels of that to get into the synovium. So we do recognize that this is a destructive disease and it's progressive. So when we're thinking about this, we should be thinking about joints, but we should think about this same type of cartilage, synovium, that can be in other places, similar to tissue that's in cardiac and pulmonary tissues. It can have renal effects. So when we see our patients and we look at their hands and we see the joint deformity, we shouldn't only be thinking, oh, it's just their hands. The reality is that these patients will actually die from heart attacks. So it is characterized by inflammatory pathways in very specific joints. You should be thinking about your PIP joint, the pannus formation, and that cartilage destruction. And it's all about that overproduction of tumor necrosis factor. There's a reason that's highlighted, because that mechanism from hyperbaric that we're going to talk about is very, focuses on TNF alpha. So typical presentation here, morning stiffness, lasting more than 1 hour. Your osteoarthritis patient is telling you it gets worse throughout the day. Your rheumatoid arthritis patient's waking up with the pain. Boggy swelling. So when you look at their hands, each joint, big, swollen joints. It's usually palpable. Oftentimes, it's accompanied with other things you see with autoimmune disease. Fatigue. Fatigue is always there. So differentiate between the two. This is something that's relatively straightforward. I always ask, did it hurt when you woke up or did it hurt at the end of the day? Typically, they're going to tell me first thing they wake up, it hurts. So there's a couple different deformities that we talk about specifically due to these joint erosions. You might see a swan neck deformity in the finger, or what we call a boutonniere deformity. Both those pictures are there. Pretty straightforward to see that. A little bit of the anatomy here, just in case you don't have that anatomy down, to recognize where the synovium is and the synoviitis, that's a hard word, where that actually happens inside the joint. So the classification criteria, this is mostly for somebody that's going to be billing insurance, because the reality is that we don't care about the criteria for treatment. We have to care about this, about getting paid if you're billing insurance, because they're gonna say, well, you have to have greater than a 6 out of 10. It has to be this joint, but not that joint. It has to be more small joints, but not those big joints. The reality of the situation is people present differently. I don't care. If they have positive, RF factor, they have morning stiffness, it hurts, the joints are boggy, I'm like, it looks like it. Let's treat it and see. So the reality is that more often than not, they do have an elevated C-reactive protein and E-sed rate, and that's what we're gonna look at for our patients to see if they're getting better. In fact, I pull these on most patients anyways. Somebody wants to ask me, how am I gonna quantify the results from hyperbarics? I'm like, let's look at inflammatory markers, C-reactive protein. And almost universally in healthy patients and our patients with autoimmune disease, it goes down. So recognize, of course, it is an autoimmune disease, so, my timer didn't start, guys. So recognize that they're autoantibodies. So even though RF factor is not specific for rheumatoid arthritis, it's pretty close. You might see the anti-citrullinated protein antibody, the anti-CCP2, much more specific to it. And then you even have other ones like the C-reactive protein levels and ESED levels that are not specific, however, they're always elevated. So cardiac manifestations, guys, their risk of heart attack is 60% higher in that first year following diagnosis. Cardiovascular disease is the leading cause of death in RA, but it's the leading cause of death in all of us. So pericarditis, we were just talking about that earlier. It's found in 30 to 50% of these patients, and vasculitis means a much more poor prognosis. Guys, we treat vasculitis with hyperbaric every single day. You are going to be helping these patients, you're gonna be saving lives by treating the inflammation associated with this. So as we look at the clinical picture, we do have to recognize that there's a genetic component to this. The reality is that the antigen binding heterodimer here that is found in 50% of people who have a genetic component associated with Crohn's, Graves', Hashimoto's, type 1 diabetes, and other autoimmune disease. You know this with your patient population. If you have one autoimmune disease, we usually find another. My patient presents with Hashimoto's, I know we're gonna find something else. So, and then we can talk a little bit more about STAT4. It does get a little deep into that. However, what I really want you guys to see is, and this is exactly what Dr. New was talking about, IL-6 and TNF-alpha. This is so important because this is your body attacking itself. These are pro-inflammatory. If you want to talk about pain and inflammation, kind of in a nutshell, those are the two I'm always looking at, and they're the two that we recognize with hyperbaric that we see a huge change in. So there are triggers that can make this worse, that make our patients present much faster. It can be Lyme disease, but tobacco abuse is absolutely one of the ones that plays a major role. Look at that, relative risk increases from 1.4 to 2.2 for smokers. It's actually a huge increase in relative risk. There is a female dominant correlation here. In fact, when I was speaking about this topic last year, we were talking about gender disparities in care because this is predominantly in women, and it really has a negative effect on women because the drugs, the DMARDs that are used here, have much worse side effects for women. Women have to make a decision, do I want to treat with this drug that is toxic, but even worse than being toxic, it's teratogenic. They can't have family planning during this time if they don't want to live in pain. It's the kind of weighing these two, it's really unfortunate. But estrogen definitely regulates this adaptive immune response. O-estrogen has that pro and anti-inflammatory depending on the cell types. And then progesterone has an immunosuppressive action. So we do recognize that for women, it does make a difference. And I don't think I've had a single adult male patient present with RA. Juvenile rheumatoid arthritis, very, very different in a lot of ways. You might see in a few men. Immune modulation, again, during pregnancy, all these symptoms might regress. You know, so it's one of the things that we do look at there, and that has something to do with the SNPs and ESR2, the estrogen receptor, and that does reduce the risk of that erosions during that time. Whereas those declining estrogen levels during menopause means it's gonna come right back. So like we said, up to 90% of patients improve during pregnancy. However, if you were taking those DMARDs, you know, the drugs that are always prescribed for this, we have to be very careful about becoming pregnant during that time. So let's talk about treatments. We're not talking about the treatments we want to talk about yet. We're going to talk about the standard of care first. The goals of therapy should be the same. We want to minimize joint pain. We want to decrease that swelling. We want to prevent deformity, decreasing those erosions, minimize adverse effects of any treatments we're doing, but really want to decrease that risk of cardiac event. We want to get people back to enjoying their lives, just restoring that quality of life. That's what the drugs are supposed to do, but they don't. So the standard of care, this is the 2020 guidelines. DMARDs are the mainstay of our RA therapy. You can use non-steroidal anti-inflammatories and corticosteroids too. And if none of that works, because eventually it will get to that point, then you have to do joint replacement. We are talking about joint replacements in fingers, and wrists, and hips, and knees, and ankle. It's outrageous how many joints we would talk about doing at that point. There are complementary and alternative treatments, and dietary and lifestyle changes play a major role. Anti-inflammatory diets, which we should all be thinking about for our joints and for our cardiac as well, but for everything, it plays a major role for these patients. Obviously, exercise and physical therapy, but how are you going to tell somebody to exercise when they can barely walk? And then hyperbaric oxygen therapy, we are going to be talking about the research protocols there. These are the drugs that are out there, and chances are you've heard these names even if you're not a medical professional, because these are all the ones that you see advertised on TV, right? Humira, Enbrel. Why do we know these names like Enbrel and Rituxan? We know them because they're outrageously expensive. Of course they can advertise on TV. Humira, $7,300 to $14,500 a month. Enbrel, $7,200 a month. Rituxan is $19,000 a month. I have a 6-year-old kid treating in one of our clinics right now who has to take Rituxan. I mean, it is outrageous. Every single time he has to go get his new infusion, they're fighting to get insurance to pay. Of course, they eventually do, but mom has basically become a full-time fighting insurance caregiver. The reality is that these drugs are so expensive, where methotrexate, as much as we might not love this drug, about $10 a month. It is definitely more commonly used overall. It should be it really should be the gold standard initially if you're using medications. DMARDs are immune suppressive. Somebody has an immune disease, so what are you gonna do? You're gonna try to shut down their immune system. So what's gonna happen? They're gonna get infections. So combination therapy with more than one DMARD means more and more infections. So hyperbaric at a bare minimum, decrease the number of infections. What other side effects are you gonna see? Loss of appetite. Well, now you don't have calories, so you can't heal. Calories are required to heal. Nausea, diarrhea, abdominal pain, rash, allergic reaction, liver dysfunction, increased risk of infection, leukopenia, anemia, thrombocytopenia. You can hear the commercial right now. You know these, you've heard them. I don't want this for my patients. I want to do as little of this as possible. We have to recognize there's time and place. Methotrexate, it is the most commonly used, but it is a pregnancy category X drug. So even a low dose of methotrexate, adverse events are common. So very, very toxic to the liver, something we want to avoid. Lots of hair loss. In fact, almost every one of my patients on methotrexate complains of hair loss. So there are potentially life-threatening side effects of these drugs. NSAIDs, so NSAIDs are COX-2 inhibitors. Guys, hyperbaric oxygen therapy is a COX-2 inhibitor. When somebody gets in your chamber and they tell you they have less pain right when they got out, you gave them a natural NSAID. Oxygen under pressure is a natural NSAID. So side effects of NSAIDs, we all know this. You're gonna give somebody a hole in their stomach, could affect their kidneys. So there's a number of over-the-counter ones. More of our patients that have RA are more likely probably taking your prescription NSAIDs. So corticosteroids, guys, nobody wants to take steroids. I mean, I can't imagine anybody here is like, yeah, those steroids, they just make me feel so good. I mean, the weight gain, the lipodystrophy of it, the round face, the buffalo hump, the weird skin changes, and then the changes in your vision. We want to avoid these if we can. Now, the things we do want to do for our patients, obviously I'm going to feed them oxygen, but the Mediterranean diet, it's one of the most commonly prescribed diets for RA, one of the more commonly prescribed diets overall, really. You guys are familiar with it, I'm not going to go over it, but it does decrease your C-reactive protein and your E-SED rate. I would recommend this for the vast majority of people. Then there is a specific diet for RA called the ITIS diet. It's not the itis like you guys all have right now. It's the end of the day, you ate too much. It's a modified Mediterranean diet, and it has the addition of much more fats, oils, some green smoothies and juices. There's actually a lot of good publications on this showing 50% of patients showed 50% improvement. And pain and swelling, less fatigue. I love it. If we could treat it with diet alone, we would, but it's not enough. Hyperbaric oxygen therapy, you guys understand at this point the majority of the mechanisms. I'm not going to go over all 13 mechanisms that Joe went over the other day. However, I do want you guys to recognize that if we reduce pro-inflammatory cytokines, IL-1 beta, IL-2, IL-6, TNF-alpha, interferon gamma, these are the ones that are very important to decrease pain and inflammation. And most importantly for all autoimmune diseases, upregulating IL-10. Think of IL-10 as your natural off switch for inflammation. I don't think people love it when I say this, but inflammation's healthy. Inflammation is the healing process. Chronic inflammation is the problem. Well, IL-10 should come out and say, all right, we healed whatever our issue is, let's calm that inflammation down. Well, if it's low, like it is in the vast majority of autoimmune disease, that chronic inflammation just gets worse and worse. By increasing that, your body's response is able to decrease, stop attacking its joints, whether it's here or other diseases we're about to talk about. Everybody has seen this picture at this point. Maybe not in this weekend, but it's one of the most commonly used. And if you look at the bottom right-hand side, or bottom left-hand side, the inflammation aspect of it, look at what we're doing. Decreasing IL-1 beta, IL-2, IL-6, TNF-alpha, interferon gamma, and it's a COX-2 inhibitor. Those are every single one of the steps we said we're concerned with rheumatoid arthritis, and then we're increasing IL-10. IL-4 as well, which has some really interesting research for cognition and some other aspects we could talk about. So I didn't realize that everybody's gonna go so deep into all the parts of hyperbaric, so I'm not gonna go into these parts here because I wanna spend a little more time on how we can use these mechanisms in other places, but at this point, everybody understands hyperbaric oxygen therapy doesn't mean more oxygen on your red blood cells. It's in your plasma. We talked about Henry's law. It's a 1,200% increase at 3.0 ATA with 100% oxygen. And we understand that oxygen is a drug, and we have to treat it that way because there's a dose-dependent relationship. There are desired effects and there's adverse effects. And so when we look at that, we do need to recognize for our patients, there is a decrease in the production of red blood cells. You know, there is the possibility of causing some airway inflammation, some fluid on the lungs. So I just want to make sure that we do recognize that there are risks and adverse events associated with it. There's effects that we talk about that are mechanical and chemical. All of these aspects are things that Joe went through. So in the interest of time, since you guys have this, we're going to jump ahead to how inflammation happens and how we're going to respond to it. So this picture here is normal inflammation in response to an injury. This could be RA, but this could be bumping your elbow as well. First, the blood vessel dilates, so blood flow increases. It gets hot. And then as fluid releases from that vessel, the fenestrations open up, it becomes red. The next step is all those white blood cells come to the area, and now that swelling and tenderness happens. It wasn't the bump in your elbow that hurt, it's your body's response because of the white blood cells and then the systemic response of those leukocytes and the cytokines causing the pain. Think of hyperbaric as doing the exact opposite of everything we just saw here. Vasoconstriction, decrease your inflammatory markers, decreasing the permeability, so less swelling, less fluid in the tissue, less of all of your leukocytes getting stuck in the vessel, getting to the area where you need it. So I don't think there's a single thing here that was not mentioned earlier today. I do love that somebody brought up platelet-derived growth factor earlier because we always talk about VEGF and not enough about platelet-derived. And we were talking about PRP at one point. Guys, I love for PRP to have my patients do a series of treatments and then get their blood draw. If I can increase your platelet-derived growth factors before taking the blood out to re-inject it, I think that would give us a better option, or a better milieu to use. However, there's no research on it. Nobody can say one versus the other. The mechanisms of action, guys, these are the proven mechanisms that Joe went through earlier. So how about the mechanisms and how they relate to rheumatoid arthritis? Minimizing joint pain. We're going to decrease our inflammatory markers. We're going to be a COX-2 inhibitor, so less pain. Vasoconstriction, less swelling. Preventing the deformity. We have 2 studies that show less joint deformity 3 and 6 months after completing treatment. We'll get into that. And minimizing adverse effects of treatment. We're not using the DMARDs that cause all those side effects. And more than anything, if we can decrease your C-reactive protein, your ESED rate, the inflammation in your blood vessels, we're going to decrease your biggest risk of mortality here, being that cardiac event. So right there, back at that inflammation alleviation part of the mechanisms we talked about. Here, right here, you can see this is our pathophysiology and what we talked about, TNF alpha, IL-1 beta. The other part that we'll talk about on that is this leads to an increased expression of adhesion molecule, and hyperbaric oxygen therapy decreases leukocyte adhesion inside the blood vessels. So we're really doing a good job of tackling almost all of the pathophys there. So as we talk about immune modulation, IL-10, I think there's gonna be so much more research on this aspect across all other autoimmune. And so that brings me to a patient that I'm thinking of here. I had a patient recently come in and they had inclusion body myositis. Don't know what that is, neither did I. And when she sat down and told me what she had, I said, I don't have any research on this, but it's a myositis. Let's look up the research and say, oh look, IL-1 beta, IL-2, IL-6. Look, all of these are the pro-inflammatory aspects of your disease process that are proven, and I know I can decrease those with hyperbaric. I think it's reasonable that we treat and see what happens. Let's just try a small series of treatments. I'm not gonna push you to do 40 treatments and then sit down, and we did 5 treatments, 5 back-to-back treatments. At our centers, we tend to treat relatively high pressure based off of the study that I'm about to show you guys. We treated at 2.0 ATA. And within 5 treatments, she told me for the first time in years, she was able to open a jug of milk. She said for the first time in years, she was able to cook for her husband without him being there. He was able to come home and she was able to be like, look what I did. It was a game changer for her. I didn't have research showing that I could treat inclusion body myositis. You're gonna end up with other autoimmune diseases that you're like, I'm not sure. I don't know. If you look at the pathophys of the disease, you should say it's reasonable or it's not. And hopefully give your patients enough of the information in a way that they can understand it to say, all right, I don't have the research that shows this is going to treat your disease, but I understand that these mechanisms are similar. I think it'd be reasonable to give it a try. So the pharmacological effects of oxygen under pressure, we talked about these are our peer-reviewed, proven mechanisms, and each one of these, for the most part, will play a role. That stem cell mobilization, if we've already had some joint destruction, we need to help rebuild it. So the effects of hyperbaric oxygen therapy on rheumatoid arthritis, there was a pilot study in 2021. They concluded that hyperbaric oxygen therapy is effective for joint pain in patients with an RA based on data from multiple validated clinical measures. They found decreased C-reactive protein and pain scores. If that's all they found in that study, that'd probably be enough. These patients, they're not coming to me complaining about, the joint deformity yet, or otherwise, I can't do my work. I can't do the things I want to do. I can't live my life because of the pain. And the decreased CRP, I know that we're stopping decreasing the vasculitis, so we're going to save their lives or extend it. The other study that we're talking about here, and this is a 2023 study, the effects of hyperbaric oxygen on MRI findings in rheumatoid arthritis. All patients demonstrated no radiologic progression of erosion, I hate this word so much, synovitis, or bone marrow edema at 3 and 6 month scans. That is fantastic. There's not a medication out there that is FDA approved to treat these diseases that you could stop taking and 3 and 6 months later not have this. Hyperbaric's not approved to treat this, but those drugs are. Those drugs that cost $20,000 a month are approved to treat this, and if you stop taking it, the joints destroy. If you continue to take it, you have infections. So it's just something to look at in that regard. So I don't think I've ever seen another study as I've looked through, and this is, I've got the citation down there. I don't think I've ever found a study that said all patients. Having every single patient is just fantastic. And so that's what kind of piqued my interest in what other patient populations should we be saying, let's take a look at hyperbaric. So what other autoimmune disease do I see every single day? Well, Hashimoto's. We see Hashimoto's. I guarantee you every single one of you has a large number of your patients with that. And so we started a study in our clinics, and we're just pulling TPO, thyroid peroxidase, labs on these patients, and we're pulling once a week. We're pulling across every single one that already has that diagnosis, that is doing daily treatment, and the reality is it's going down. And I can't say that this is going to be a study that shows that hyperbaric makes this change, but I got to tell you, my patients that have done a large series of treatments, and our patients like to stick with us for some time, but our patients that have done 200 treatments, 300 treatments, almost universally come back and tell me that they've had to lower their thyroid medication. There's something going on here that we are going to figure out. So that's one autoimmune that we see all the time. How about your patients that have GI autoimmune? Because I know every single one of you has had a patient, you're like, yeah, it is like a light switch for them. I see the hands back there. I mean, it is outrageous what you do for your patients that have any GI autoimmune disease. It is so quick to see that change. I mean, your gut's job is to absorb, and that turnover is so fast. So if you look at it, you're gonna say, all right, is it reasonable that IL-1 beta, IL-6, TNF alpha, if I decrease those in those tissues? Because I don't have FDA-approved studies showing that I can treat, Crohn's disease, but I look at it, I'm like, wait, hold on a sec, Crohn's is abscess. Abscesses are wounds. Hyperbaric treats wounds. I think that sounds reasonable that might be able to work here. Anybody have patients with Crohn's? Yeah, how are your patients with Crohn's doing? Fantastic, right? Most of our patients that have Crohn's are no longer treating with the standard of care. Those are patients that have done maybe 100 to 300 treatments. So the inflammatory markers, like we talked about, significantly lowered at 3 and 6 months post HBOT. I could not find another study, anything after 6 months, and that's what I'd love to do. And if anybody else would like to work on these studies with us, now that we have the journal, I will always be happy to contribute to that. And these are not expensive labs. C-reactive protein, E-cedrate, I mean, these are very, very reasonably priced labs. It's not like pulling everybody's telomeres, otherwise like that. So that significant reduction in pain did last all the way through that 6 months as well. And then the increased sleep quality. We take that for granted when we sleep well. And when we don't, and if you have somebody that has an autoimmune disease that's constantly not sleeping well because of inflammation, that's the number one thing they're gonna come back and tell you. Is like, they come back and I'm like, how are things changing? What do you know? So like, I sleep so well. I'm like, but what about your hands? No, that is what affects them. During their sleep is where growth factors come out. It's how they heal. If they can't sleep, the growth factors don't come out, they don't heal. So I think the most significant effect there is also not having to use drugs that stop somebody being able to have family planning and decide to have children if they'd like to. So I think that it allows people to promote their reproductive options by using hyperbaric. We talk about hyperbaric fertility all the time. We talk about that with infertility. We don't really think about it so much with medications. So it just gives another option. So I actually ended up a little bit earlier there with this, so I wanted to actually go back and look at just one thing here, because I don't know how I burned through that so fast. I guess I didn't go over mechanisms. There we go. So the reason I wanted to come back to this slide specifically, it was about that enhanced angiogenesis. And it says fibroblasts need a partial pressure of oxygen of greater than 30 millimeters of mercury. The reason I like this slide, and I like to bring this up, is we talk about pressure here a lot. And there's different thoughts on pressure quite often, because I come from the high pressure world. And I have changed my thoughts significantly on that. I treat myself at lower pressure than I ever have in the past. A lot of my patients are treating at lower pressure. I have patients who are treating at 2.8 and 3.0 as well. So I do treat across the spectrum there. But we recognize that the science shows certain cell lines, certain tissues require certain pressures. So when we talk about treating at very low pressures to get brand new blood vessels to grow otherwise, I think it's really important to recognize that we do need the science to back up the partial pressure in that tissue to grow that. The partial pressure needed to get into bone. So I think it's important that we look at, there's a reason that some of the approved indications are extremely high pressure. There's a reason that now doing more and more treatment, we recognize that lower pressure for neural tissue makes much more sense. There's a reason why we treat the most sensitive tissue first. I picked that up from Jason. I watched one of his videos and I sat there and was like, I'm sitting here treating my patient that has this knee inflammation, and I'm not thinking about that they really came to me with this terrible concussion. Otherwise, I should start them very low because I should be treating the most sensitive tissue. But here I'm looking at that meniscus that needs high pressure, and the meniscus does need high pressure. So I just kind of wanted to end on that point. I still am ending relatively early, so I could take a question if anybody has one. All the way back there, that question? No? No, I'm just pointing, nobody has their hands up.
If you don't have a question yet, we will still have the panel, so if you guys want to think of it.
All right. All right, thank you guys so much. If anybody